right, welcome back. I'm Nolan Kelly, Chief Customer Officer at 1upHealth.
And I'm Kevin Yamashita. I lead our customer enablement team here at the company.
Thanks for joining us again. Round 3, Kev.
Oh, crazy. Where's time go?
We're back for more.
Yeah. No, last time we talked, you teased us. Art of the necessary, not art of the possible.
I know.
Well, we're here to talk about that. What does that mean?
It means the first 2 times we had these sessions, we focused on truly the art of the possible. There's some regulatory changes. There's a lot of change happening in the industry. What does that mean for the incumbents and the new entrants in this in healthcare? And how can they operate differently? What are all the new and unique ways to continue to advance and change how healthcare is delivered, really with a focus on data, right? Data centricity, but sort of with a lens of imagination, right? All the cool things that can happen.
Optimism. Yeah.
Yeah.
What could you do? Why?
Exactly. And I had thought, or we had thought together that while there's a lot that can be done in the art of the possible, the focus really needs to be on like, what is necessary, right? Like, why is all this change happening? Why is it happening now? And sure, it's fun to think of everything that can happen and to dream that way, but like we're kind of in a tough place in the industry right now. And there's a reason why there's all this regulation. There's a reason why all this change is happening, right? So let's focus on that. Let's focus on the here and the now and really driving change that's necessary in the industry. That was kind of the thesis.
Love that. Let's focus on things that are in front of us, right? The real challenge that we can solve. And it's like you said, it's nice to dream, but at the end of the day, I think the impact is felt with the real things, and it's hard work, one step at a time that gets us there.
Yeah. So we're going to tell the narrative through 4 themes, and those themes have articles that we'll reference. We'll link them into the video so folks can kind of click over and read them on their own. But I'd like to go through 4 trends in particular. The first one is around, and we'll focus on Medicare Advantage. Right? That's kind of the proxy for what's happening in the industry, the canary in the coal mine, so to speak.
No, for those that don't have that context, Medicare Advantage, what do you mean by that?
I mean, private insurance carriers that are essentially doing the work of Medicare for the federal government, right? So federal government paying private insurers to deliver Medicare, real focus on utilization management, network management, helping the Medicare members achieve a better care through the Medicare system.
Got it. So when most people hear Medicare, they think of kind of a monolithic government program. You're telling me that there's private insurance carriers that support some of these workflows as well? Interesting.
That's what I'm telling you, Kev.
Love it.
Yeah.
Okay, I guess I might have known that. Now we all do.
But it's a great indicator for what's happening, more broadly across the healthcare industry.
Which is why I raise this. I think that trend of privatization and trying to enable the free market to start to solve some of these problems. I think that's an important piece of this story. And I want to
free market.
Yeah. What is that?
Exactly. What is it in healthcare? So let's talk about a couple trends. The first is the utilization growth in the MA space, right? And we saw some really interesting stuff coming out of earnings calls in terms of Q1 cost trends. So we'll talk about that. I'd like to talk about the very recent CMS news around their rates that they're going to set for fiscal year 2025.
They finalized that a couple of weeks ago. It's pretty recent. Yeah.
It's pretty recent. Yeah, exactly. Some trends that are happening with providers and their interactions with Medicare Advantage plans. And then last, but certainly not least, we kind of bury the lead here, what that means for patients and consumers.
Yeah.
Right.
Yeah. I have a feeling it's not good.
Not great. It's not great. So do you want to open? Do you want me to talk about the first one?
Take us away.
Okay. So the first trend really is around what we saw in Q1 earnings calls from a lot of our large insurers, the Humanas and CVS's, Uniteds of the world, as they were reporting on Q4 earnings, right? A tremendous uptick in utilization, a tremendous uptick in costs, and a subsequent drop in profit and a subsequent drop in stock prices, right? And sort of the cascading effect of all that. Humana had a $541 million loss that they reported in Q4 of 2023, right? So we're seeing the cost growth in the MA plans, and I mean, is that something that we can continue to weather as an industry?
Yeah, it's kind of remarkable when you think about it, because I remember, even 2-3 years ago, folks were looking at MA as this shiny new toy, right?
Right.
Oh, we can improve care delivery quality and we can reduce costs. And how many startups had incredible valuations around MA business models, right? But now we're seeing all these, incumbent vendors and kind of the big dogs realizing that there's no silver bullet, there's no magic, right? Like
Yeah.
the fundamentals still matter. And if you miss the mark on those fundamentals, your profit margin is going to be taking a haircut.
Well, there's an underlying thesis that the private insurance plans, this is what they do. They build products and they bring services to the marketplace to help these members better manage their care, right? They can understand the risk of these members. They have care management program offerings and the such. And that collaboration that's required between the payer and provider is really at the center of success in these plans.
Right.
And we're seeing that not really happen.
Yeah, I mean, fundamentally, I think this is an operational challenge on the part of the health insurance organizations, right? I think you said it best. MA profitability is really driven by utilization, right? And how do you control utilization? It's just simple operational levers.
Yeah.
Don't have line of sight. If you're not sharing data, if you don't have visibility of these things, you can't control it.
Right. So, okay, so let's go from the first one there, which is the MA plan saying it's costing a lot to run these plans, and we're paying our providers more to deliver care for these members. Well, CMS just issued their fiscal year 25 rates, right? And when they set the preliminary rates, there was a lot of pushback from the industry saying we need more. The rate increases proposed for 25 aren't enough. And when that happens, normally CMS goes back and they move things around a little bit, and you'll see an adjustment up when they publish the final rates. That didn't happen this time around.
Yeah.
Right. So you're having CMS, the piggy bank, say, you know what, we're not going to bail you out this time.
That's remarkable. Yeah. Maybe it shouldn't be remarkable, but it is.
Yeah.
Right. There's no magic answer.
What signal does that send?
Well, I think the signal is really that there has to be a different way to make do with the resources that we have, right? So in so many ways, we've gotten all these get out of jail free cards in the healthcare space. The system doesn't work. Let's come up with a new program. Let's pour more money. Let's offload this and innovate that. I think at the end of the day, the signal from the government is that there are rules to the game, and we now need everyone to play by those rules. And if you're not going to make money based on the rules of the game, like I said before, the market is free.
Yeah.
There will be winners and losers. I think the problem, the frustration here is that with healthcare, we all use it. So if there's losers, we all lose.
Yeah. And don't get me wrong, there's still rate increases happening in fiscal year 25. They're just not to the degree that the industry is saying is necessary.
Right. And I think in some ways, as a American citizen, as a taxpayer, part of that makes me happy, right? Like this is my money, this is your money that's being spent on all these programs. There should be accountability.
We said this just the other day. You look at your W-2 every 2 weeks, you get your pay stub. Sorry, not your W-2. You look at your pay stub every 2 weeks, and there's a line item that says what you are contributing to the Medicare, Medicare fund. So, as a taxpayer, as a citizen, you might be okay with that.
But it's a hard spot to be in, because I also want to make sure that our brethren here are getting the care that they need.
Yeah.
How do you balance that?
Right. Yeah. No, it's not easy. All right. So, costs going up, utilization going up, CMS saying we're not going to continue to respond to exactly what the market demands are, and we're going to put other levers in the market. And we're seeing this with regulation and policy, right? Something we're paying close attention to. There's another trend which might be most disturbing, which is what's happening on the health system side, the hospitals.
Ooh, this is terrifying.
They're contemplating, and some are even actually pursuing, not accepting MA insurance anymore. Why is that?
Oh, that's crazy. Well, I think there's a handful of reasons, but at a very fundamental level, I think the providers are seeing that they're the ones that are losing out when it comes to the economics here. And if you really kind of think about it simply, providers want to provide as much care as they can, and payers want to pay as little as possible. And at the end of the day, who are the folks that lose out? It's the providers that want to continue delivering care that are not getting reimbursed for the care they're delivering. Because it's really hard when you have someone sitting in front of you that has this need to ignore them, to send them away.
Yeah.
And I think we all get into healthcare space for these altruistic reasons. So one empathizes and one understands. But then when you wait 3 to 6 weeks and you get denial letters from, the health insurance organizations, or you have prior authorization processes you can't get through, all that friction there. If you're a provider, why do you want to play those games?
Yeah.
And
this isn't to, point a finger per se, or to say, someone's a bad actor, someone's not a bad actor. It's all, how do we all work better together to create a system? And these 3 groups we'll start with here, right? Your MA plan, CMS as the largest payer of healthcare in the country, and then your providers who are on the front lines delivering care. Like, this is fundamentally broken. 61% of hospital executives are saying that they are either planning to drop an MA plan or contemplating dropping an MA plan. That is a terrifying shift.
That's terrifying, right? And I think a lot of this is based on a fundamental lack of trust.
Right.
We set up these rules and all these systems, and we hope that folks operate in logical, thoughtful ways. What I think we're seeing in the industry is that this trust had eroded and eroded and eroded, and because of that, what is logical for an individual organization to be successful and profitable and sustainable is not what's logical to deliver better care across the country. And the thing that terrifies me most is you think about Medicare Advantage, and you think about a lot of these organizations. These are elderly citizens. These are folks with a lot of healthcare needs, and they're the ones that are no longer going to have access to providers. Right? These are not young, healthy people where we can say, go find a different PCP and they will be fine. These are people that might have long relationships with these provider organizations that now need to find different docs on different systems.
Yeah.
And when we talk about the instability of the industry and these death spirals of some of the fundamental economics, you have 60% of providers pulling out of MA collapses just from a very simple supply and demand perspective.
Right.
What does that mean? This is happening fast.
Yeah, no, it definitely is. You started to go right to the patient, which is the fourth trend I want to talk about, which isn't totally in the middle of Medicare Advantage, but certainly is right there, and that is the cost sharing and the cost burden that's now on the consumer. And Massachusetts had put out a study recently, and again we'll link to this. Enrollment in high deductible plans. High deductible plans were going to be one of the saviors to enable cost shifting and have consumer influence the demand curve in the industry.
Right, the same way that 401k solved the pension crisis.
Exactly. Yeah, just like it. And it's almost what it's done is it's added just another layer of cost on the industry. Employer group costs continue to go up, and now the employers are bearing a bigger piece of that. Over the last 10 years, enrollment in high deductible plans has gone from 16% to 42%. And what's happening is the consumer, the patient, the member, the employee is literally paying for their insurance and then having to make a decision if they can afford to go get healthcare. I was speaking with a former colleague the other day who called this group the uninsured insureds, right? And what a disservice the system has done to that population, right?
Yeah. Oh, it's remarkable. And I think there's a whole bunch of different dimensions that get lost in the shuffle, and you started to call them out. It is, the premium cost of your insurance coverage.
Yeah.
It is the amount of your deductible and the amount of cost sharing that routes through. But then there's other pieces too. You think about, basic costs for, drugs in the formulary. You think about co-insurance rates, right? Even if you get beyond your premiums and your deductibles, there's still all this other crop that sits on top to redirect some of this cost back to the consumer.
Yep.
It's unsustainable.
It is, but it's impacting care, right? So you have 1 in 3 patients who are putting off or postponing care due to the cost.
Yeah.
These are insured people in the United States of America. 1 in 3 are postponing or putting off care. 1 in 5 are not filling prescriptions, or they're rationing or skipping their medications because of costs. Again, these are citizens of this country who have insurance plans with pharmacy coverage in place, and this is the cost that they bear on top of their coverage.
Right, and it's one thing to say it is the end of the plan year. I'm going to wait 3 weeks to go get this procedure, or I'm going to try to front load this now to play the game, and that's not good.
Yep.
But it makes a little bit of sense, right? To say that I'm not going to fulfill my maintenance medications, for the next 6 months because I can't afford it. That's different entirely.
Yeah.
And I think some of the irony here, at least that resonates with me, is on one hand, we here in the US look to prescriptions and maintenance medications for a lot of population level health, outcomes that we desire, we yearn for. On the other hand, the prices of prescription drugs continue to increase. And I think that's one of the things that's called out in the Massachusetts survey, as well as some national surveys that we can point to.
Yeah.
So in a lot of ways, yet again, this silver bullet, the solution that we had to the problem is becoming the problem.
Yeah.
What do we do?
Well, I mean, I think we bring it back to why we're even talking today, right? It's this concept of the art of the necessary. So we've had these sort of utopian type discussions recently that are around data flowing more freely, across the industry and the adoption of FHIR and RESTful APIs and the such. Some of those regulations don't take hold until 2027. Around prior auth and provider access and peer-to-peer and others. And but what we're shining a light on here is really the system and how it operates today, and the providers, providers that are losing faith in and not, no longer willing to put up with some of the challenges of the MA plans. You have the actual MA payers who are saying the financial solvency of these programs is in question, right? You have CMS saying, we're not going to bail you out anymore. And you have the consumer holding the bag saying, man, I probably can't get the care that I need, even though I pay for it and have paid for it for years.
And what's horrible is I believe that the MA population is increasing in the country, right?
Right.
So we are throwing more people into this conundrum, into this quagmire.
So how do we bring that back to, the art of the necessary? What do we have to do today to change some of this?
Yeah, well, one of the things that I think is kind of interesting is as, provider organizations contemplate dropping MA plans, there are some that are saying we are not going to drop all MA plans, but we are going to focus on partnership with one or two insurance organizations specifically, those that align better with our values, those where we have, more trust or a better working relationship. That's really interesting to me, right? Because it comes back to this idea of payer, provider, patient collaboration. And what is at the center of that?
Yeah.
Interoperability. Data sharing. If we can all agree on the facts, on the details, then I think we can have a higher order conversation based on trust, a little bit of optimism, some pragmatism, right? So like you said, there are all these regulations that eventually kick in, a number of years, provider access, payer to payer, prior authorization, improvement to the patient access API. In some ways, I see this as CMS giving everyone a bit of a life raft, right? The system's not working. We can't communicate effectively. There's a lack of trust. But look, here's a standard that we can all agree on. Here's a framework for operating, for sharing data, right? The floor is falling out from under us. And here is CMS with the answer. Here's a tool that you can use to collaborate better.
Yeah.
To start to solve these problems in a cohesive, thoughtful, sustainable, scalable way, using technology to work smarter, not harder.
Yep.
No, I gotta be careful because now I'm starting to get a little bit art of the possible, right? But I think that's what this is it's being able to say, here is this great opportunity, here is this critical problem, and the time to act is now. And I think that's what I'd leave people with.
Yeah, totally agree. That, separate the wheat from the chaff a little bit. The problem exists, and CMS is saying, to your point, the opportunity. We're giving you the tools, industry, right? We have put regulations out there. We've given you the tools to be successful. We're not going to open the bank further. And we need you to figure out how to run this system more effectively and efficiently. And interoperability, data availability, data exchange, as has happened in other industries, in this internet economy, needs to take shape faster in healthcare.
Yeah.
That's what gets us out of this.
Absolutely. And I think I'd push all of us, because if we're not on Medicare today, we'll be on Medicare tomorrow.
I don't know. We're still young. All right, Kev, thanks for the time. Always enjoy catching up with you.
It's a pleasure.
For dialing in and listening to today's episode. And we look forward to catching up in a couple weeks.
Cheers.